So we'll be starting with Cushing syndrome. Cushing syndrome is basically a constellation of symptoms that occur on chronic exposure to glucocorticoids. So it is a group of symptoms and signs that occur when a patient or a person is going to be exposed to a chronic exposure of glucocorticoids. So Cushing syndrome can be exogenous, that is, the patient is taking steroids from outside, maybe knowingly or unknowingly. For example, if the patient is taking prednisolone and he is taking it in the dose of 10 mg and he was advised to take it for a period of 2 weeks to 3 weeks, and he or she has continued this for a good amount of 6 months. So this is known as exogenous. One thing we need to understand is that it's not only the oral route or the IV route or the IM route, but it is the topical routes such as a betamethasone or a clobetasone ointment that can also cause the same constellation of symptoms. So the classical learning that we have had is that whenever we are giving a topical therapy, that topical therapy will save us from the systemic adverse events that are occurring because of the exposure to the drug. But that is not the case when it comes to glucocorticoids. Even in case of topical, even in case of eye drops, there can be certain symptoms that can mimic your Cushing syndrome. Rather, mimicking is not the correct word. It's just the constellation of symptoms occurring even on topical or other routes of administration. And this remains the most common cause of Cushing syndrome. Now coming on to endogenous. Endogenous Cushing syndrome, on the other hand, is divided into two types. One is the ACTH dependent or the ACTH independent. So this ACTH dependent is the most common is ACTH secreting pituitary adenoma. This is the most common cause of the ACTH dependent type, and ACTH dependent is the most common type of endogenous Cushing's. So endogenous actually accounts for 90% of the. So the second one is an ectopic ACTH secreting tumor. Third is a CRH secreting tumor. The fourth is macronodular adrenal hyperplasia. And the last one is treatment with ACTH. So we treat certain conditions such as Salam seizures with ACTH. Now the drug of choice there is, I think, vigabatrin, but ACTH given to a patient for a long time can also cause these kind of symptoms. While the ACTH independent causes are as follows. ACTH independent causes. So the ACTH independent causes are adrenal adenoma, adrenal carcinoma, McCune-Albright syndrome. McCune-Albright syndrome is very important. It's a triad of fibrous polyosteotic, fibrous dysplasias, precocious puberty, and also cafe au lait spots. Then there is PPNAD, primary pigmented nodular adrenal disease, and AIMAH, that is ACTH independent macronodular adrenal hyperplasia. So these are the ACTH independent causes. Now coming on to certain miscellaneous causes, we can say that the most common cause of Cushing syndrome is exogenous. The most common cause of Cushing's syndrome, which is endogenous, is ACTH secreting pituitary adenoma. This is also known as Cushing's disease. So the pituitary cause of Cushing's is known as the Cushing's disease. Now, the most common cause of Cushing's syndrome in an infant is McCune-Albright syndrome. The most common cause of Cushing syndrome in a toddler 3 to 8 years, let's say, is adrenocortical carcinoma. And after this, the most common cause of Cushing syndrome in adolescents or young adults is the same, exogenous followed by endogenous, in which Cushing's disease is the most common. Alright. So what else can happen in case of Cushing's is there can be something known as pseudo Cushing's. States. So they may have certain subtle features of Cushing syndrome plus anomalous non-suppressibility on overnight DEXA suppression tests. So, what are these? These may be obesity, can be depression, alcoholism, or pregnancy. So these are the causes of pseudo Cushing's. And why this occurs here is because they are pro-inflammatory states producing your pro-inflammatory cytokines such as IL-1, IL-6 and TNF-alpha. And what they are going to do is they are going to positively impact the hypothalamic pituitary adrenal axis. This activation will lead to certain increase in the cortisol levels, and this can lead to some Cushing syndrome like features. So this is our Cushing syndrome. We can just revise it. The most common cause is exogenous. This exogenous cause as well as the endogenous cause. So endogenous cause, among them exogenous is most common. Among endogenous, the ACTH dependent is most common. So if this accounts for 90% of the endogenous causes, while ACTH independent accounts for 10% of the total causes. Now we saw the ACTH secreting pituitary adenoma as well as the other causes such as the ectopic ACTH, the ectopic CRH. We also saw macronodular adrenal hyperplasia and ACTH as a treatment. While in pituitary independent, we saw adrenal adenoma, adrenal carcinoma, then we saw our PPNAD and AIMAH, and we also saw McCune-Albright syndrome. Alright. So here we come down to the classification of Cushing syndrome. In case of ACTH dependent causes, what we need to see? So that kind of a patient will be a female patient that will come to you with an insidious onset of weight gain, may come to you with an insidious onset of headache, with some sort of bruisability, with some sort of redness on the face, rounding of the face, a centripetal obesity, and or some sort of visual disturbances may also occur with certain changes in the skin, in the mood, or in case of menstrual problems there may be oligomenorrhea, which remains the most common menstrual abnormality. So most of the causes in Cushing syndrome, what we have to see is, in case of ACTH dependence, are going to be ACTH secreting pituitary adenoma. This adenoma is going to be 90% of the time a microadenoma, that is less than 1 centimeter or less than 10 mm. While in case of 10% cases, it is going to be a macroadenoma, that is more than 1 centimeter or more than 10 mm. Now, in this case, as we discussed, it is going to be an insidious disease. Patient is not going to come to you suddenly. He will say that I have had weight gain over a period of 6 months, 2 years, 3 years, like that. So it is an insidious onset. It is a female preponderance. of around 4:1. Then they may have a middle or younger age, that is around 20 to 40 years. But in certain Indian studies, the mean age is around 43. Again, with a female preponderance. Because it is a ACTH dependent cause, the ACTH is going to also have along with it alpha MSH. This will further act on the receptors and this will cause hyperpigmentation. So this hyperpigmentation is going to be patient may present like there is a change in the complexion, blackening of skin, which may be visible even on the lips, mucous membranes, on the dorsum of the tongue, hands, mainly the dorsum. So mainly these kind of areas, which is also known as the sun exposed areas. So there may be hyperpigmentation. Then features of adrenal as well as androgen excess may be there. What does that mean? See, the cortex has 3 layers: zona glomerulosa, zona fasciculata, zona reticularis, each producing its own hormones, mineralocorticoids, the glucocorticoids and the androgens. ACTH is produced in alarming amounts, so that is going to act on the adrenal cortex. So it will produce primarily the glucocorticoids but in large amounts. This cortisol that is produced from the fasciculata layer will saturate an enzyme which is 11 beta HSD type 2, which converts cortisol to cortisone. It will saturate this. Once it saturates, it will start acting on the mineralocorticoid receptors, and once that happens, that will cause hypertension, that will cause hypokalemia, and hypernatremia can occur. Plus it will act on the zona reticularis layer to increase the adrenal androgens, specifically the DHEAS, which is exclusive to the adrenals. It may also increase DHEA or the other precursors. So this will cause problems because this may lead to, it will be a rapid onset, it will be a male gender, it will be a severe kind of proximal myopathy. It can have some hyperpigmentation, but never the kind of hyperpigmentation that you will get in ACTH dependence. So no hyperpigmentation is the thing we need to keep in mind. In case of eutopic disease, while it may not be present to that extent, weight gain can be the most common presenting sign or symptom. Then after this, hypertension or hypokalemia. So this is a very important point, that in case of a Cushing's disease, that is a eutopic ACTH dependent cause, we can have hypertension and hypokalemia in around 10 to 15% of the cases. While in case of an ectopic ACTH production, where the main causes are actually going to be your small cell lung carcinomas, non-small cell carcinomas, or FEOs or medullary thyroid carcinomas, so they will have a inadvertently high rate of hypertension and hypokalemia. Alright. Now, in case of ACTH, what it is going to be having? So, ACTH more than 20 picogram per ml is going to be suggestive of ACTH dependent causes, while ACTH more than 90 picogram per ml suggests an ectopic cause. The signs of protein catabolism. May be present, they will be present in the Cushing's disease, while they may be absent in case of ectopic ACTH because it is rapid onset as opposed to insidious onset in case of ACTH dependent pituitary adenoma. While the ectopic are classically going to be your rapid onset diseases. After this, what we need to see is that what is the gender preponderance. So here it is going to be female more than male, that is 4:1, while here male preponderance is going to be there. Now in case of HDDST, which is the high dose DEXA suppression test, which is done, we give dexamethasone 2 mg every 6 hourly, and after 48 hours we test for the serum cortisol levels, and if they are, that is the absolute value is going to be less than 50% of the basal value, while if after 48 hours also the serum cortisol levels are not going to be less than 50%, that is they are not going to be suppressed, non-suppressive. So this is the main crux of the matter. Ectopic ones, the causes are small cell lung carcinomas. They account for 50% of the total causes. Then we can also see that the non-small cell lung carcinomas, the pheochromocytomas or the paragangliomas, they account only for 3 to 5% cases. Then comes your medullary thyroid carcinoma, then the PNETs, that is the pancreatic, neuro, endocrine tumors. Alright, and there may be ovarian tumors or even teratomas, sometimes miscellaneous carcinoids, midgut most commonly, followed by foregut. So these are the causes of ectopic ACTH. So why this ectopic ACTH is not going to be suppressed by high dose DEXA suppression test? So we are giving 2 mg every 6 hourly for 48 hours. and then we are testing for serum cortisol 8 am. Alright, so and we are doing serum cortisol before starting the test. So this value and this value, so this value should be suppressed to less than 50%. Its absolute value should be less than 50% of basal value. So for example, it is 10 here, so it should be suppressed to less than 5. That's what I am trying to say. So the main thing is, that is, in case of the pituitary dependence, the negative feedback from steroids, in our case dexamethasone, is going to be increased. So for the normal set point, say for example we are giving 2 mg dexa for 6 hourly for 48 hours, this should cause the suppression. If it is pituitary dependent, because the end point for suppression or the negative feedback is just slightly increased. But in case of ectopic ACTH, this whole system is disrupted. So the negative feedback is set at a very, very high set point and hence does not get suppressed. While when we look at our adrenal carcinomas, there what we find is the ACTH independent causes. So coming on to the adrenal independent causes. After the adrenal dependent causes, which we considered as the pituitary cause, that is the ACTH dependent eutopic causes versus the ectopic ACTH secretion. So ACTH independent cause, the prototype example is adrenocortical carcinoma. Here the age is going to be of very grave importance, less than 10 years or more than 50 years. There is a bimodal sense of incidence in certain age groups. Secondly, there is going to be male preponderance here. There is going to be a rapidity of onset. There is going to be ACTH is going to be low, so there is going to be no hyperpigmentation. Very less features of protein catabolism and there are going to be features of hirsutism, that is because of the adrenal androgen axis, and presence of virilization. And it can also present in a child as isosexual or heterosexual precocity. What is this isosexual heterosexual? Isosexual precocity is that there is a male and that male is getting the precocious signs of puberty, that is the secondary sexual characters of a male itself. While in case of heterosexual, it's a female child, and because of the androgen excess, she is getting virilized. Virilization means that there is either clitoromegaly, there can be pitch of voice is changed, there can be hirsutism, the hair growth pattern is going to change to male pattern, that is temporal balding is going to occur. So these are the things that may occur. So a female is having a secondary sexual characters of a male, so that is going to be heterosexual precocity. Now, after coming to this, we have certain variants of Cushing syndrome, such as cyclical Cushing syndrome and subclinical Cushing syndrome. So what are they? So cyclical Cushing syndrome is basically that there is hypercortisolism is there, but there is a waxing and waning with anomalous dynamic test. Waxing and waning features with a anomalous dynamic tests. So we define it as 3 peaks plus 2 troughs. That is like this. It is going like this. So it has to have 3 peaks and 2 troughs. So these are the 2 troughs and these are the 3 peaks that are occurring. Alright. So frequent monitoring is needed. So what we cannot do here is serum cortisol monitoring, because it may be less, it may be more. So we have to monitor via 2 tests, which are the urinary free cortisol test or the late night salivary cortisol test. And we may also see that we also have to do the urinary cortisol to creatinine test or the hair cortisol test. So this we have to do. And why this occurs is because of cyclical hormogenesis. So why it can occur? Because of cyclical hormogenesis. So sometimes there is a increase in the production, so there may be a peak here. There is a reduction, so there may be a trough, or there can be recurrent hemorrhages into the tumor, causing the troughs and peaks. This has been proposed to be because of the early programmed death of the pituitary cells. So this is what is known as the cyclical Cushing's, while subclinical Cushing's is what is known as lack of specific signs and symptoms of Cushing syndrome, but there is evidence of autonomous glucocorticoid secretion. So there is lack of specific Cushing syndrome features. We'll get to those. Specific signs are those that are going to have a discriminant factor. So in case of, say, we do not screen for Cushing's in every obese individual that is coming to us, or every person who is having some sort of uncontrolled hypertension or diabetes. There are certain features that we'll discuss further, such as plethora, bruisability, proximal myopathy, stria. So these are the features that are going to be specific. So there is a lack of those features here, but there is evidence of autonomous cortisol secretion. So what we are going to do is, where we are going to see this is in usually adrenal incidentalomas or adenomas. And if we are going to perform an ONDST, so how we are going to find that there is a autonomous cortisol secretion? We will do an ONDST. ONDST is overnight DEXA suppression test. Here we give 1 mg of dexamethasone at 11 p.m. and what we do is we take a 8 am cortisol. Ideally it should be less than 1.8 microgram per deciliter, but if it is more than 5 microgram per deciliter, it shows some sort of autonomous cortisol secretion, and the surrogate marker can be DHEAS. So in case of DHEAS, here what we are going to find is that if the ACTH is causing this kind of autonomous secretion, that is, if the pituitary is causing this, it will cause increase in the DHEAS along with increase in the ACTH. But here if we do DHEAS and ACTH, what is going to happen is both DHEAS plus ACTH are going to come low. Why? Because they are going to come low because this is not pituitary dependent. Pituitary is not causing this cortisol secretion. This cortisol secretion is actually occurring autonomously. That autonomous secretion is occurring directly from the adrenals. So that adrenal is going to secrete your glucocorticoid. It will not secrete your adrenal androgens. So that adrenal androgens are not going to be secreted unless it is a ACTH pan stimulation of the adrenals, where all three layers are going to produce the respective hormones. So that is why DHEAS and ACTH are going to be reduced in case of subclinical Cushing syndrome, and cortisol itself is going to be slightly high, which is more than 1.8 microgram per deciliter. Classically it is around more than 5 microgram per deciliter or more than 135 nanomole per liter. So this is your subclinical Cushing's. So coming on to certain other features, like, so we have discussed ACTH dependent causes, among which we have discussed the pituitary cause, that is ACTH secreting adenoma. We have discussed the ectopic ACTH secreting tumors. Then we are going to discuss the CRH secreting tumors. So we are going to discuss this CRH secreting. tumors. So what are those? Classically, those CRH secreting tumors are going to be your bronchial carcinoids, bronchial carcinoids are going to be your classical examples. So they are basically going to be very slow growing. Alright, they are very slow growing. The other cause is going to be your medullary thyroid carcinoma, and the third is going to be CA prostate. These are the three causes. So what this is happening is that CRH is actually being produced ectopically. This is ectopic ACTH के बाद there is ectopic CRH secreting tumor. So the CRH is ectopic, but this CRH may be produced from bronchial carcinoid, that is in your lungs, and here this CRH is produced. This is going to act on your pituitary, and the pituitary is going to produce your ACTH. Alright, and this will have all the features then of your Cushing syndrome. So we need to remember this, that ACTH is from the pituitary only, and this is ACTH dependent cause. But like ACTH was being produced ectopically in case of the ectopic ACTH syndrome, where the classical example was small cell lung carcinoma, here the CRH is going to be produced ectopically, but the secretion of ACTH occurs from the pituitary itself. And here the examples are three: the bronchial carcinoid, the MTC, as well as the CA prostate. Alright, now coming on to the other causes, such as the MAH. This was also one of the causes of your ACTH dependent Cushing syndrome. So macronodular adrenal hyperplasia. So what it is? It is basically because of long standing ACTH stimulation. Say for example, there is a child that is, or an adult that is being given ACTH treatment, and because of this ACTH stimulation there is hypertrophy of the adrenal cortex. तो क्या होगा? So there will be nodule formation. This nodule formation starts producing cortisol autonomously, and this leads to an auto suppression of ACTH. So ACTH was being given, it was stimulating the adrenal cortex, that adrenal cortex started growing, that growth led to nodule formation, that nodule was also stimulated to such an extent that it started producing cortisol on its own. This cortisol now on its own is going to have a negative feedback on ACTH. This ACTH now is going to get suppressed. This is known as autosuppression. Alright, and this then leads to low ACTH. So even though this is a ACTH dependent cause of Cushing's, but the ACTH here is low. That is the beauty of this. Alright. Now coming on to two features rather than two diseases. One is primary pigmented nodular adrenal disease, which is PPNAD. We have finished our ACTH dependent causes. So what are the ACTH dependent causes? The pituitary adenoma, ACTH was being secreted there. Then the ectopic ACTH production was there. After that, the ectopic CRH production was there. Then there is macronodular adrenal hyperplasia was there. After that, we have seen that ACTH treatment can also lead to this ACTH dependent Cushing syndrome. Now, coming on to our ACTH independent causes. So we have discussed adrenal adenomas slightly and adrenal carcinomas, and in due course of time we will discuss them further. Now coming on to the certain causes that are very important and very specific. So one has to know them in order to diagnose. So they are PPNAD and AIMAH. So first coming on to PPNAD, it is a ACTH independent cause there is this ACTH independent cause. This is the most important line. After this, what you need to remember is there are going to be bilateral small, often pigmented adrenal nodules, mostly occurring in less than 15 years of age. 90% of them are going to be associated with Carney's complex, which is a autosomal dominant disease. It's a genetic cause with mutation most commonly in PRKAR1A. So what is this PRKAR1A? It is protein kinase A regulatory subunit 1A. Alright, so this is going to present like this. On histopathology, they are going to present like very small nodules less than 5 mm, and they are going to have the following features. So what are they going to have? They are going to have एक मिनट पॉज कर दीजिए, पॉज कर दीजिए। हाँ,
पॉज नहीं होगा,
हाँ कट, मतलब कब तक का कट हो जाएगा इसमें?
मतलब नई रिकॉर्डिंग होगी इसके।
हाँ ठीक है ना। So what we are going to have is less than 5 mm of nodules that are going to be having our string of beads appearance on CT. While on histopathology, they are going to have internodular hypertrophy. This is very important. So this internodular hypertrophy with small less than 5 mm of nodules with pigmentation. Alright, and very subtle features are going to be there of protein catabolism. So ACTH is going to be suppressed, and there is something known as paradoxical rise in serum cortisol after performing our high dose DEXA suppression test. So basically what we are doing is we are giving again 2 mg of your DEXA, we are giving every 6 hours for 48 hours, and this should ideally suppress the serum cortisol. This should suppress to less than 50% of the absolute basal value of cortisol, or more than 50% decrement should occur. Alright, but here what happens in PPNAD, if we are giving this DEXA, it is causing increase in the serum cortisol levels. So what we can do here is, this sentence is going to cause some sort of confusion. So we are going to remove this sentence. We are just going to remember one single thing, that we have given 2 mg of DEXA for 6 hours, 48 every 6 hours for 48 hours, and this should cause reduction of more than 50% in the post suppression cortisol value. But here there is a paradoxical increase in cortisol. So why that is occurring? So why that is occurring is, there is increase, there are two reasons. One is, there is increased glucocorticoid receptor expression on adrenocortical cells. On your adrenocortical cells. So what is happening is that, because the receptor levels are very high, so this DEXA should ideally suppress the cortisol, but it is rather because of the high density of this glucocorticoid receptor, it is ending up stimulating it. And there is also a non-genomic effect. There is a non-genomic effect of this dexamethasone, and this will cause stimulation, as there is protein kinase A mutation is there. Usually what it is doing is, this protein kinase suppression should be there non-genomically, but that is not happening. This protein kinase A that we have seen in PRKAR1A, that is mutated. So there is a non-genomic effect of dexamethasone, which is actually mediated by protein kinase A, and because this protein kinase A is malfunctioning, this is causing an abnormal increase in the cortisol value post the HDDST, which ideally should not occur. So we can just revise this PPNAD. PPNAD main things we need to remember are that it is ACTH independent, it is having less than 5 mm nodules which are pigmented, which are also going to have internodular hypertrophy. They occur less than 15 years of age. 90% of the time they are associated with Carney's complex. And autosomal dominant nature of inheritance, that we have to remember. What else we would like to remember here is, what is Carney's complex? So Carney's complex is basically a constellation of certain symptoms, such as, most importantly, it is the skin. So in case of skin, there are going to be pigmented lesions, lentiginous and cutaneous myxomas. Lentiginous, cutaneous myxomas, or there are going to be blue nevi. This is very classical. Then cardiac This occurs in 80% of the cases. Cardiac myxomas are also going to be seen in 72% cases, while PPNAD is going to be seen in 45% cases, all cases of Carnes. Then there can be testicular tumors. Then there are going to be pituitary lesions. This is of importance to us. So most common pituitary lesion here is going to be a GH secretion in 10% of the cases. This is followed by the other causes. There are going to be gastric schwannomas, there can be thyroid related carcinomas, acoustic neuromas, or hepatomas. Now coming on to the other cause of ACTH independent causes of Cushing syndrome. So we have discussed some in brief ACTH independent causes such as adrenal adenomas, adrenocortical carcinomas, then followed by PPNAD. We have also briefly discussed our McCune Albright also. Then after this we come to ACTH independent macronodular adrenal hyperplasia. So what is this? This ACTH independent macronodular adrenal hyperplasia is having illicit stimulation of adrenal gland by wide variety of peptides. So what are this wide variety of peptides that can cause this stimulation? That is GIP, gastric inhibitory peptide. So what is this known as? It is basically known as food associated or food induced hypercortisolism. So that can occur. Now after that, what other peptides are there? There can be arginine vasopressin, there can be beta adrenergic receptors, there can be LH receptor, HCG, there can be serotonin, there can be angiotensin 2, there can be also leptin. So these are the peptides that can cause some sort of illicit stimulation leading to these features of Cushing syndrome or cortisol excess primarily. So they do have what you call as a familial preponderance. Familial preponderance is there is no gender predilection. The age of presentation in PPNAD was less than 15 years. Here the age of presentation is middle age. Then they have bilateral adrenal nodules of, so there we saw that it was a small nodule of less than 5 mm. Here we see that they are more than 10 mm and they have nodular hyperplasia with internodular atrophy more commonly than hypertrophy. Both can occur, but atrophy is more common. Alright, and if this occurs in case of familial cause which we saw, so that the gene there implicated is ARMC5. It is armadillo copy 5 gene. Alright. So that finishes our AIMAH also. And what is the treatment of choice here? In such cases, we need to go for bilateral adrenalectomy. Treatment of choice for AIMAH. Alright.